Good afternoon and welcome to Robert Gordon University's first question time relating to advanced practice. And as part of our celebrations of the second National Advanced Practice Week, we brought together an esteemed panel of staff relating to advanced practice who we're going to address our questions to. So if we could just get you to start, Pauline.
Hi, I'm Pauline Donaldson. I'm the Children and Young People's Course Lead.
Hi, I'm Linda Harper, Associate Nurse Director for Practice Nursing and the Lead Nurse for the Out of Hours Service and Murray Health and Social Care Partnership.
Hi, I'm Trudy McIntosh. I'm a Senior Lecturer in the School of Pharmacy and Life Sciences. I'm the Pharmacist Prescribing Lead and I also lead on teaching non-medical prescribing in the School of Nursing and Midwifery.
I'm Gordon Riley. I'm one of the lecturers in advanced practice at R.G.U.
And I'm Nicola Browney, route leader of the clinical practice route of the MAC programme. Today I'll be chairing the panel.
Hi, I'm Katrina Kennedy. I'm the Queen's Nursing Institute Scotland Professor of Community Nursing in the School of Nursing and Midwifery.
Hello, Karen Kindness, Nurse Consultant for Advanced Practice NHS Grampian, covering acute sector.
Hi, I'm Alison Mogich, Advanced Nurse Practitioner and Nurse Consultant for Primary Care in NHS Grampian.
Okay, so we're just going to begin with a question that we've had come in through Twitter this afternoon. So the first question that we've been asked is, should advanced practice be a recordable qualification? And I'm going to give that to Karen.
Thank you, Nicola. I know there's been a lot of debate about this, and I think there's a sort of practical answer and there's possibly an ideal answer. Ideally, I think it probably should be a recordable qualification, but I think the practicalities of that are that there is a general move away from trying to subdivide the nursing profession, and there's definitely a move towards us embracing the full extent of our nursing role under the current guidance of the NMC. So I think realistically, I think it's probably not going to be the direction of travel, and we need to build on the work that's been done nationally to have Scottish national guidance and board implementation of the proper qualification and competency assessment for our advanced practitioners.
Linda, is there anything you would like to add to that in relation to advanced practice being a recordable qualification?
Yeah, my view is I take on board Karen's view, and I realise the difference, there is practical considerations, but my view is it definitely should be a recordable qualification. Same as your non-medical prescribing is a recordable qualification, then as an advanced nurse practitioner it should be recordable.
Anybody else care to comment in relation to that?
I think they're finding that hard to hear.
Is there any way we can make this microphone louder, John?
It's just for the camera.
Okay. We don't have one for... No. Okay. We'll speak louder. Okay, sorry. Okay, so moving on from that then, a second question that we had coming in via email today was, the research pillar of the advanced practice role seems to be the least developed. What are the key challenges in driving this forward? And we're going to give this one to Katrina.
Thank you very much. Can you hear me okay? The fact that the research component of the AMP role is the least developed is confirmed when you look at the evidence around advanced practice roles. I did a very quick search today just to confirm that remained the case, and there is virtually nothing written about advanced nurse practitioners and the type of research role that they might undertake. So I think there's three challenges from my sort of reading of the situation around advanced practice. And the first is around the culture of nursing and midwifery, which emphasises direct patient and family care. And I think that rightly is a priority within nursing and midwifery practice. But in some ways it means that academic work, particularly research, doesn't necessarily fit that well in terms of what people think nursing and midwifery practice is about. I think one of the other challenges is around leadership for research, and I mean in both the clinical areas and in education. Clinical areas are very busy, a lot of workload, staffing issues, and the same applies in the education context where we have heavy teaching loads and it's difficult to free staff up. So I think leadership issues and commitment at a strategic and managerial level is absolutely essential, and that we have to try and make research more visible and view it as more than a hobby or for the select few. The third thing that I think is a challenge is the infrastructure in terms of what career opportunities we can offer nurses to combine clinical and research work. I think our medical colleagues can do this quite well, but somehow we haven't quite managed it in terms of nursing and midwifery practice. So I think these are three areas that we've all got a responsibility to look for. I suppose there is a question about how reasonable is it to expect ENPs to undertake independent research, and I'll maybe say more about that later. But I think in terms of the challenges, these for me lie around the culture, the leadership and the infrastructure that we currently work within.
Thank you for that, Katrina. Alison, perhaps as a nurse consultant out in the community, maybe you could build on that as to what challenges there are for nurses in an advanced role to actually undertake active research or to be part of a research team.
Yes, so certainly just echoing exactly what's just been said. At the moment, we're building up a multidisciplinary team of advanced clinical practice. And to do that, we're using our existing ANPs as experts to build on the ones that we're needing to build up to that level of practice, whether it be physios, OTs, pharmacists, the multidisciplinary team. So in itself, already we're actually planning a platform for research because we're starting with a new foundation. And we're going to use universities to help us with the research, and that's the ideal start to making it part of our role. It's difficult when you've got to put on the 4 pillars, but if we can use our partners and our HEIs appropriately, then we can actually benchmark a new beginning of collaborating for research, for leadership, and for the infrastructure we're trying to achieve. This is governed by the Scottish Government and the partnership in working within other healthcare providers, but also by the members of the public who are also quite important in our research. So adding in some parameters for them to be involved in the research platform might be helpful for us to build a new agenda. So I think for advanced practice at the moment, research hasn't been forgotten, we've just started.
Okay, thank you for that, Alison. Okay, anybody else want to comment on that? All happy? Okay, so moving on to the next question then that we've had come in. Should it be essential for allied health professionals and nursing to complete the full MAC to merit the title of an advanced practitioner? Perhaps I'll start with you, Gordon.
I think I would agree with that for parity, especially from my background in being a paramedic, we should follow the lead from nursing and to be an advanced paramedic. And that's now been recognised and agreed by the College of Paramedics that advanced paramedics should have a master's degree.
Thank you. Linda, can I ask your thoughts on that as well?
Yeah, I think it should be the full master's programme, but I can understand the Scottish Government's rationale and that group in saying that initially they could exit at PG DIP. I suppose a lot of the advanced nurse practitioners that we have just now are probably like myself and on the upper ages. So therefore, and some probably have not got a first degree, and it might be very difficult for them to jump straight to masters, but I think in time it will be a master's qualification that you will have to have, and as far as I'm aware that would be the Scottish Government's aim, that it will be the full master's qualification.
Trudy, what about in pharmacy? What's your beliefs or thoughts?
Thanks. We don't really have such a well-developed structure for advanced practitioners. We're starting a new advanced pharmacy practice MSc course in January, which we hope is going to be attractive. It's going to include the pharmacist prescribing qualification in the diploma stage, and we certainly see that prescribing is part of advanced practice for pharmacists. Our course is at master's level. We anticipate that around half the students that we have go on to the MSc bit of the programme, but around half will exit at diploma stage. And we don't need them to have the MSc in order to get the qualification, but it'll be a diploma rather than a degree. Of course, I think it's always better to go on to the MSc stage, whether that's done by research or whether it's done by portfolio, by workplace-based portfolio. Certainly we think that for advanced pharmacy practitioners, they should be doing the research based in their workplace, so it's useful not just to get the qualification, but also so that they can build on the findings of their research in the relevant area, and hopefully use their findings to improve practice. So yes, I think it should be master's level, and I think people should be encouraged to go on to MSc, but that's certainly a challenge for a number of people, perhaps less academic, very competent, but people who maybe find academic writing and so on difficult. And so I think it's important that the support should be there, both from the higher education institutions and also from the workplace.
Thank you.
Thanks.
That probably leads us on nicely to another question that's come in relation to the research then. And Katrina, I'll maybe start back with you again. What should or could be done about the research role of the advanced nurse practitioner or advanced practitioner, and how should that look?
I think that maybe just to follow on, I think there is growing evidence that the higher the educational attainment of practitioners, then the better the patient outcomes. We've certainly got growing evidence of that from things like the RN forecast, which was a large European study. And also there's been quite a recent survey of ANPs in New Zealand, and it showed quite clearly that there was better engagement across the 4 domains from people that had completed a full master's. So I think there is growing evidence that education can impact in terms of patient and family outcomes. I suppose for me, there's in the university we work with something around defining independent researchers. And that's quite a high bar, which is okay for people based in academia. But when thinking about people who are balancing a lot of different components, then I suppose you have to ask, is it reasonable to expect ANPs to be independent researchers as we might define them in this context? And I don't think it is for many people. I suppose my own view is that one size doesn't fit all. And that when ANP roles are being developed, then there has to be agreement as to the purpose of that role and to what extent research engagement is important. I think the point you made about nurses not working in silos for me is absolutely critical. I think maybe we've been a wee bit precious about nursing research, but we work all the time in teams, and I think our research teams similarly should reflect the multidisciplinary makeup of the work that we actually do. So I suppose my view is that I think the ANP role in research, I think there should be something in all of those roles, but the level at which it might be about being discerning users of research and using that with the teams that they work with. I think that's something all nurses need, but an advanced practitioner you would hope would be working with a team and bringing a team along through more of the audit quality improvement cycle. And for some, it may well be that the research remit meets more of the criteria of being an independent researcher, but I don't think across the board that that's actually achievable and maybe not desirable actually. And I think that maybe I've long thought that advanced nurse practice roles perhaps need to decide on the pillars on which they're going to focus, and that maybe focusing on 2 out of the 4 is more achievable. I had an ANP role way back in the early 90s when it was just becoming fashionable, and actually the remit was very much about developing educational opportunities for qualified district nurses and other community nurses, and that actually worked quite well. So I don't think that one size can fit all, but it's something that we should be looking at in terms of scoping out what the need for the role is and what purpose we want it to serve.
Thank you. Karen, perhaps I can pass this on to you then. So as an employer, thinking about job descriptions, how transparent is it within the role of an advanced practitioner that this is a requirement of that role?
That's been a bit of a journey, how the 4 pillars of practice are addressed within job descriptions for, if you will, jobbing ANPs who are out in clinical practice. So historically and indeed practically, the majority of them are still 100% clinical. They have no time for anything else. They generally, I think, meet their education and facilitation of learning pillar relatively easily, because working as part of multidisciplinary teams, there are opportunities to share knowledge in a sort of on the hoof kind of way. And some of them do formally teach on various programmes, and I know Nicola has a few folk that she utilises from various areas of practice to complement the learning within various modules. What we've done within NHS Grampian since the Scottish National work is the core job description for any new ANPs coming on board do have a dedicated percentage of time specifically against the 4 pillars of practice. It's not as much as I would like to see, but at least it is formally within their job description. And I have to say I would tend to agree with Katrina. I think at that level, the coalface ANP, I think addressing the 4 pillars is probably unachievable. But for those, they all have to be primarily clinical because it's the nature of their job. But you could have a special interest in education, one that perhaps can see themselves as a lecturer down the line would maybe take more of a focus on teaching. Perhaps somebody with more of an aspiration towards research could perhaps pick up that percentage around research, and those that perhaps saw themselves as leading the future of advanced nursing practice could develop a bit more of a leadership role. As I say, at the moment, realistically, all 4, I think, is probably not achievable.
Thank you, Karen. Moving on to the next question and change in direction. It's from a parent from Aberdeen City Centre who's commented that it seems that there are less advanced practitioners in both the children and midwifery settings, and she wonders why that should be. So I'll hand that to you, Pauline.
Although I'm based in education, it's probably a question that the member of the public is fair to ask. I don't know the answer to that question, why there aren't advanced practitioners that have a speciality in paediatrics. I think if you look at advanced practice and how we develop individuals within that 4 pillars and how they build their confidence and competence in looking after patients and families across the age spectrum from 0 to elderly care, the core principles are there, as in the decision makings, following guidelines and referring on to specialist services thereon are essential. I think the key thing we need to keep focusing on is what service we're offering to the population, where we're delivering that service, and is it the right place for that individual. And Grampian's probably got one of the biggest challenges because of the large remote rural area that we cover, and with that is quite a young population. I know advanced practitioners' workloads, just through speaking to some advanced practitioners, they're looking at 30 to 40% of their workloads are under 16s. So we talk about generic or across the lifespan, and I think that's key points. But there are developments in advanced paediatric roles, probably more south of Scotland area, in the central belt, where we're looking at acute posts. And I know in Grampian we have got at least 2 or 3 practitioners that are doing master's programmes on advanced paediatric modules that are working in advanced roles already, but they don't. It's a language you use about advanced roles and specialist nurse roles, and it's elements of that practice that they're advancing in. Does that answer your question?
Thanks. And then I suppose back to you, perhaps, Linda, in your role. So, do you have any children advanced practitioners in your area, or how do you prepare adult nurses to look after children as well?
And we only have one member of staff on the bank, actually, who's also a paediatric nurse as well as a general nurse. But we do see children out of hours. We see a lot of children, and we prepare them they have quite an extensive shadowed time or in-house training programme with us, and within that time they spend time in the Sick Children's Hospital. They carry out the module that's delivered here by R.G.U. in terms of the management of the acutely unwell child and young person. They all have to do that, and they are also assessed by their clinical mentor, which is usually a GP and an experienced ANP within their in-house training programme. And they also have regular teaching from a GP during their training programme. And that teaching goes on for all staff on a 8-weekly basis. And I think probably in terms of the generalist and adult nurse, there's probably more of us an advanced clinical nurse practitioner role because of the workforce issues, and perhaps those issues are less in children's nursing, because I think the recruitment and retention probably is a little bit better there. But I think they will be coming on board, and there are more and more areas looking to develop children's nurses into advanced clinical nurse practitioners, and in terms of midwifery. But again, it's how you define the advanced bit, isn't it?
Trudy, what about from a pharmacy perspective? Do you think that the undergraduate training in pharmacy prepares practitioners better to treat all ages across the lifespan, perhaps compared to nursing, and then it's easier for pharmacists to become advanced practitioners post-reg?
All right. Well, that's two questions. The first question is then, does the undergraduate M-Pharm prepare pharmacists to treat people across the whole spectrum? And I think that's true. We do have elements where the students will focus in the third year module on communication with children and managing minor ailments for children. But I don't think we do an awful lot specifically in paediatrics or around birth and so on. I don't think we do very much around a pregnancy, general, but not very much. I don't know. There are certainly specialists working in paediatrics in the Children's Hospital and so on, but I think those probably postgraduate qualifications that they would do and experience and qualifications they would get after registration and after a few years general training. I think, from what I understand, there are advanced nurse practitioners, so that is a recognised title. I think that there are beginning to be pharmacists. There are certainly courses like ours, which is advanced pharmacy practice or advanced pharmacy practitioners or something, but I think the role is less well defined. But I think there are certainly people working at advanced level, and it's good that they can be recognised as such. I don't know about the focus particularly in children and young people. There are people working probably in secondary care rather than primary care who have a focus in that area. But I think probably most pharmacists would be looking across the age spectrum, and particularly at the elderly, given polypharmacy issues and so on among the elderly. Okay.
Thank you. Before moving on to the next question we have here, is there a question from the audience?
Thank you. What is the difference between an advanced nurse practitioner and a general practitioner?
Thank you. So what is the difference between an AMP, an advanced practitioner, and a general practitioner, your GP? I'll maybe give that to Alison.
So, first of all, it's a different profession with a different regulatory body, a different mapping of education, and they've got a lot of protection in their student years as medical students. They've got different supervision, they've got different clinical supervision, they've got different mapping of competencies. We are trying to align that for nurses, and I think we're well on the way of looking at medical models in the nursing models and developing the role for advanced practice. But I think if I was being, because I'm quite clinical still, and I never perceive myself as a doctor, I see myself proud as an advanced nurse practitioner with an added level of skill that comes up to a level of practice that allows me to call myself an advanced nurse practitioner under the registration of my NMC Code of Conduct. A doctor is a doctor in their right, and they've got different responsibilities, different plans, different ethos to the journey of the patient. Together, we give care that's excellent. In silos, I don't believe we do. So our education has to map to some level of excellence together, but not the same. And I hope I've explained that in words that the public can also recognise the difference. It's okay to have an advanced nurse practitioner manage your acute illness, but it's also okay to have a pharmacist manage your acute illness, a paramedic, a physiotherapist. It's the right person at the right time, at the right place for you, for your journey as a patient receiving that health care. And I think collaboration of acute, primary care and all the other feeder services will provide a new platform for patient care of the future. Realistic medicine, ownership, something like that. Thank you.
I was involved in evaluating advanced nurse practitioner roles in palliative care for Macmillan Cancer Support, and similarly the advanced practitioners were very clear that they weren't doctors and that they weren't trying to be doctors. And I suppose what we found was that yes, they had advanced clinical skills and they could do a lot of things that some of the doctors do. But where the contribution from them as ANPs came in that ability to be able to initiate some of the medical things that were required, but alongside recognising holistic patient and family focused care. And I suppose what we came out with was that, you know, through these roles they were developing new professional identities. There was blurring of boundaries, but these were new nursing roles and definitely not medical roles. And everybody was quite clear about that because we interviewed the whole multidisciplinary teams, so that included the doctors as well. But the doctors also recognised that the nurses did something that they couldn't do in terms of a much more holistic approach to patient care.
I suppose that takes us on nicely to our next question then. So with that in mind, from Alison and Katrina's answer then, should there be one governing body then for the purpose of advanced practice if we're all kind of working in collaboration, or do we need to keep our separate identities? Gordon?
I think it is a bit fragmented at the moment, and ideally I would like to be under the same umbrella as every other healthcare professional at an advanced level. I think there'd be parity across the board, delivering the same level of care to our patients and sharing the burden of accountability as well. I think there is some alignment already following on from the nurses' lead. Ultimately, I think that would be a great idea, definitely to recognise advanced practice as a profession and to be shared across the multidisciplinary team.
Trudy, seeing as you're governed by the HCPC, do you have similar thoughts?
We're not governed by the HCPC, we're governed by the General Pharmaceutical Council. And I think there has been discussion as to whether they could have one healthcare regulator. And I think they're thinking that pharmacy should be separate from some of the other ones because of the different role that it has. But I'm not altogether up to speed with the discussions around that. But I think they've decided that it shouldn't be one, that it might be a role for two perhaps, and lumping certain healthcare professions together. I think that each profession has, things to contribute, and I think different professions have different elements they do very well. You speak about the holistic care that you can get from nurse practitioners. Hopefully pharmacists are the experts in medicine, so I think that we need to be careful not to sort of merge into a general healthcare practitioner and lose the specialities that each profession has. I think it should be about multidisciplinary working with others, recognising each other's strengths and limitations and where we can contribute best to providing the best patient care. I think that given a shortage of doctors, certainly in primary care, the way that primary care is being delivered has to change, and it is changing. And I think it's very much about multidisciplinary working together, and not everyone trying to become a sort of generic healthcare professional.
Karen, what's your thoughts? Can we all live happily under one governing body, or do we remain separate?
I think it's a really interesting question. Personally, I don't think we could sit comfortably all under the same umbrella necessarily. I've contributed to some discussion about this where there was a consultation through the General Medical Council asking these types of questions about some categories of advanced clinical practitioners and having the desire to have them all under one umbrella. And the problem you get there is I can understand the desire for consistency no matter what your healthcare professional background, in terms of if you're meeting a particular clinical remit, that they have the same standards for all. But I think you can achieve that through the education. The problem that a number of us with nursing or midwifery or physiotherapy backgrounds saw when we were contributing to that consultation was, what do you do with your primary registration? If you're taking on a new registration for a different role, then would you have to give up your primary registration? And if you didn't, if you had a dual registration, which takes precedence? So for us it raised more questions than it answered, and I think most of us were more comfortable sticking with our primary healthcare professional registration, but addressing the needs of consistency in particular roles through an academic and clinical competency portfolio to evidence how you met the requirements of that role.
Is there another question from the audience before we move on?
Hi, we speak a lot about primary care. You have spoken a lot about primary care, AMPs and GPs and that. So I'd like to know what you think the role of the AMP and the district nursing service is within primary care, because district nursing service is an essential role within the GP practice. So where does AMP stand with that, considering we are now at master's level as advanced nurse practitioners ourselves?
Katrina, do you want to start? No? Alison?
Yeah.
Okay, so it's a difficult one, but we've got a paper to help us align the decisions we'll make for our professions and our different silos of practice. So the district nursing's got a paper identifying competencies and frameworks to help them enable not just the academic studies that they've undertaken, but also the clinical skill and looking at their caseload, and also working with the virtual ward community and in collaboration with the advanced nurse practitioners. So district nursing are district nurses, and that's their title. Advanced nurse practitioners are advanced nurse practitioners, and that's their title. Are there areas for a district nurse can become an advanced nurse practitioner? Yes. Paper 3 would align it to advancing practice. So once we've achieved the level 6, then moving on to level 7 for advanced practice and looking at the competencies, the framework and the development of your own service that is really quite vital in the community for looking after what we call the patient's preference. It's care at home, care in the community, using the virtual wards, health and social care partnership, and again all the alliances we've just spoken about. So district nursing isn't lost in advanced practice, it's just developing, and we're still developing the framework through paper 3, and I would say watch this space. Thank you.
I think there's a danger that sometimes we can get a bit caught up on the titles and the words, because actually when you look at the literature around specialist and advanced practice, it's actually very difficult to discern between them at the moment. We did something quite recently and did quite an extensive review of the literature, and these terms are used interchangeably across different countries and different contexts, and that many specialist nursing roles would have similar expectation around higher levels of decision making and advanced clinical skill and such like. So it maybe doesn't answer your question, but I suppose it's important that district nurses, and I am a district nurse by background, raise the profile of what district nurses do, rather than maybe us getting too hung up on what we're called and where we fit. And I think there's definitely an urgent need for district nurses to do more research to make clear what it is their district nursing role actually contributes to patient and family care.
Linda, do you want to add anything to that?
No, not really. I think it is. We do get hung up about this advanced nurse practitioner and advanced and the specialist, but actually there's very little difference in the level that you're working at. It's just that we're doing different things, but at the same level really, and the district nurse has lots of skills that perhaps are at advanced level and is working at advanced level, but it might be doing a little bit of a different job to what the advanced nurse practitioner is doing, but your skills are no less or no at no lower level than my skills as an advanced nurse practitioner. And I think and there is a role perhaps for within teams to have a district nurse that perhaps has her district nursing skills as well as some of advanced nurse practitioner skills, which will enable you to keep people at home, the more acutely unwell person at home perhaps. Within that multidisciplinary team, it's that teamwork, isn't it? And you need everybody to make up that team so that we can deliver the care that the patient requires, really.
Is there anything you want to address back to the panel, or were you happy with that response? Okay. So moving on, thinking about Brexit then, with what's going on currently at the moment, it's very topical as it has been for the past few months. What concerns does the panel have about Brexit and the impact that might have on advanced practice in the future? Pauline, do you want to take that one?
I guess I've probably got a question to put back to people that are on Twitter and maybe the audience out in front of us, is that we're talking about nurses' roles and all our different professions all coming together for the service and the care we want to provide for that person at the right time. And it's really interesting that your discussion about district nurses and how that role's evolving and how we all fit together and how we provide a service. I guess one of my concerns is that in paediatrics, and this is just going by public conferences, is like, well, how do we provide, and I'm going to say children and young people because that's my area of interest, how are we going to provide the right service in the right place for that population? And is it about maybe looking at our traditional roles, but also being really mindful that as nurses, and we work within an NMC competency framework, and our pre-reg programme and new proficiencies are got competencies for our paediatric nurses to care for children in acute and community environments. So it'll be interesting to know what the public want, what the public needs are, and where they see care for children in the future in line with Brexit. And I've not really answered the Brexit question because I don't know the answer. And if anybody does have the answer and what the future looks like, I would be really interested to hear from them. There we go, your turn.
No, sorry, I don't have the answer. I don't know. I don't think we fully understand the implications of what Brexit might bring, not just in healthcare, but in lots of other things.
What about from the research perspective then, Katrina? Do you have grave concerns about Brexit, or are you quite happy how things are progressing?
No. Don't have the answers, but no, we're not happy. I mean, I think like every other area, it's really unknown. The big thing from a research point of view for the universities is the access to European funding, which I think is still quite unclear as to how that's going to pan out. And that, I mean, it is quite hard anyway for nurses and midwives to get funding for the kind of research we do. So if there's a shortage of money at European level, a lot of the big hitters will be targeting UK-based resource, so it's going to have a knock-on effect. So I think, you know, it's pretty uncertain times all round, and research in many respects is a bit of a, you know, as I said, you know, it might be seen as a hobby or an added luxury in professions such as nursing, where our focus is around patient and family care. But I suppose specifically from the ANP point of view, all the pressures on the workforce are likely to intensify the focus on advanced nurse practitioners having very heavy clinical loads, which will preclude any opportunity for them to maybe work within the other three pillars, just because of the necessity to meet the priorities of the service.
Do you want to add something, Kyle? From an acute hospital perspective, I certainly have grave concerns about the ability of European healthcare professionals that want to come and work in the UK having the ability to do that limited in any way. We have a massive numbers of our in-hospital medical staff, nursing staff, allied health professionals that do come from Europe, and if we lose them, I think we're going to be struggling, actually. We also have lots of non-Europeans as well. It's very multicultural, very diverse, lovely environment in many respects to work in. But none of us who actually work in those areas want to lose any of our colleagues, whether from Europe or elsewhere.
Yeah, and I'll absolutely agree. I think focusing on what's going to happen with Brexit, I think I'm pushing it back to what's happening now. We've got a health service that is running on thin layers, and we're marking multidisciplinary teams to help build the infrastructure. At the moment, we can't find general practitioners to come and work in the remote and rural areas. We've got closures of general practices. We've got people moving to different areas for their more affluent, for their get better pay, better money, better service. So I think Brexit is going to have an impact, but actually the impact's here. That's what I would say.
Okay, thank you. Changing tack then slightly with our next question. With advanced practice constantly evolving and pushing boundaries and changing jobs and service delivery, a question comes in relation to indemnity and how well covered are staff in relation to that aspect of advancing practice and ever-changing roles. Any takers?
It's a very challenging question, and in primary care we've got kind of two kind of silos that will work. So independent practitioners, so the nurses that go and work within the GP practices will be indemnified by RCN as long as they involve them, but they have to also be on the practice indemnity for that to be able to be equitable, I think. The luxury that we've got in NHS Grampian is obviously with the Advanced Care Academy and the establishment of fellows working within the academy, fellows working within the bank of the academy. We can identitise them working in general practice through NHS Grampian, and that gives them a better support and a better indemnity to work within that advancing roles. It is very blurred for the indemnity of the nurses working at that advanced level. For the point of view from vicarious liability, I think the doctor that's employing that advanced nurse practitioner still has some responsibility for their professional conduct with the nurse if they're well supported, etc. But it is very blurry. But maybe Linda will maybe help clarify that within the general practice arena. For the NHS Grampian arena, if you work within NHS Grampian, your contracts within NHS Grampian, you'll be indemnitised with NHS Grampian as well as other staff.
Linda, do you care to comment further?
Yeah. So the RCN won't provide indemnity if you're employed by an independent contractor. The indemnity is provided by the independent contractor. The RCN will provide support if there are workplace issues, if there are terms and conditions issues, but not actually around clinical issues. They did in the past, but I think it's probably, I don't know, maybe 5-6 years ago, they said that they will no longer indemnify around clinical issues. That should be the employer, as it is with the NHS. It's the NHS that provides the indemnity for that. And I know GPs pay a huge amount for their indemnity, so whether advanced nurse practitioners need to think about that, I'm not sure, but I think if you're employed by a board, then the board will take that indemnity for you, and just now, as should your independent contractor, but it's probably worthwhile having that discussion with them just to ensure that you have good indemnity cover.
I was just going to say that I'm not altogether clear about where the indemnity comes from and whether, if push came to shove, for example in primary care, the GP's indemnity would cover a pharmacist prescriber or a non-medical prescriber. And one of the things we say to our students is that they have to find out how they're covered, whether they need to get independent cover. We would always recommend that, because it's nice to have someone in your corner independently working for you rather than relying on the insurance offered by your employer. And certainly as a pharmacist, I have my own professional indemnity insurance. Even though I'm working only in a university now, I still pay that every year because I like to know that I've got that in addition to the insurance that the RGU has for me. So we would always advise people to make very careful inquiries about that and be very clear that they have an appropriate level of cover. I think that's a really important message for everybody.
Thank you. And kind of following on from that then, we've had a question relating to non-medical prescribing, so it kind of ties into that. It's from a nurse who feels that she's been pressured from the off really to prescribe widely rather than within a small area until she gains competence. Do you have concerns about that, Trudy, or how do you think we can manage that?
Again, I think that's a really important issue. I teach non-medical prescribers as well as pharmacist prescribers, and across the board, some of them are prescribing for very niche areas, very small or discrete patient groups, and some of them are treating anything and everything that comes in the door. The new medical contract in Scotland pushes a lot of prescribing onto pharmacists, and I think we have concerns as a profession that people should not be coerced into doing something beyond their competence. We're not many doctors. Doctors will have areas where they're more competent and areas where they refer on to somebody else. A colleague in their practice maybe specialises in respiratory or cardiovascular or something. And I think it's really important that non-medical prescribers are strongly supported to identify for themselves where they feel competent to prescribe and where they don't. I think there's a huge difference between, as pharmacists, doing a polypharmacy review, making recommendations which you then pass on to somebody else to review and action. There's a huge difference between that and making independent prescribing decisions and putting your name at the bottom of the prescription, knowing that there may not be that second level of review. And I think it's really important that all the professions who are involved in non-medical prescribing support their members to define for themselves where they will prescribe and where they won't prescribe. And I think there is pressure. I think people are coerced. The expectation is that, well, you're a prescriber, so there's some prescriptions to sign. And it's self-assessed competency, and I think it's really important that non-medical prescribers, relatively new professions even for nurses and pharmacists, have been doing it for more than 10 years now, but still a relatively new type of prescriber, and I think it's really important that they are encouraged and supported by their organisations and the professional bodies to stick within their own areas of self-identified competence.
Linda, as lead prescribed for Grampian, do you have any other thoughts?
No, I would agree with Trudy. We all work within our code. We all have our code of conduct. We all have to work within our competencies. And if you do not feel you're competent, if you have not had any training in that area of prescribing, then you really need to say no. And it is up to you to say no, because I'm not sure at the end of the day if you don't. How supported you will be actually. So really in terms of your own professionalism and following your code of conduct, if you are not experienced in that area of prescribing, you need to say no.
One of the definitions of independent non-medical prescribing is someone who's responsible and accountable for the clinical management of conditions, including prescribing. So there's an accountability there. And if things go wrong, it will be no excuse to say, oh, well, a big boy told me to do it. I was pressurised into doing this, and what could I do? I just had to agree. You don't have to agree. It's self-assessed competence, and it's really important that people stay within that.
Thank you. Okay, moving on, we have a question from the audience.
So this is a question from Jane Mayer in Glasgow. I have no idea who Jane Mayer is, but she's in Glasgow. And what I want to know is, what are the implications to advanced practice education in the future with the new NMC standards for undergraduate nursing, where some advanced skills will be introduced?
I've got another one.
Pauline, we'll give that one to you.
If anything, I don't think it has any implication. It's just going to enhance nursing care as a whole. It's a language of advanced skills, and what's in the new proficiencies is skills within that area or field specific, and the landscape's changing of what our population's health needs are, and with that as a workforce we need to change as well. So although we use the language advanced, it's actually, we have new graduates at the point of being on the register, having core skills that are essential for looking after the area population that they're graduating in. So I don't think it has anything. If anything, it's going to enhance the quality of care, and I think that's what we're all here for. And it's about working within that sphere of practice. So again, it comes back to the initial question we had, where it's about, do we need our separate registrations or under one registration? The debate we've had about non-medical prescribing, we're all talking about the same thing. It's about patient safety, quality of care, working within our own sphere of practice and our own area of accountability.
Karen, can I ask you what you think about the new NMC standards for pre-reg?
I would agree with Pauline that it's a move in the right direction in enhancing what nurses can offer to the patient journey, to have that more consistent level of skill. I would absolutely debate around the advanced terminology. I think a lot of that is historic. Nursing has been on a very rapid journey where what they do on a day-to-day basis in terms of patient care has almost changed beyond all recognition in the last, well, certainly over my career, starting from the sort of mid-80s to now. What you did when you newly qualified in the 80s is not what newly qualified nurses do now, and that is going to carry on changing. So I absolutely welcome the new pre-registration standards as being more aligned with what nurses are currently required to do on a day-to-day basis, and get that consistent education and exposure to that practice as part of pre-registration. What I think it will help to do is help people to understand advanced practice, and precisely because of the speed of the journey nursing has been on, people can be lagging behind a little bit, and their expectations of what healthcare professional should be doing for them. They might perceive some of what is now standard nursing practice as advanced because it was out with the remit of a normal nurse even only 10 years ago. And that's just the journey we're on, and I think what advanced means will continue to evolve over the next few years. And it's part of our jobs within our respective roles within education and within NHS to try and make sure that people understand what current roles are and what is advanced and what isn't advanced, what is actually now normal nursing, and making sure that where we are enhancing the roles of nurses or midwives or allied health professionals or anybody, that is done in a structured and thoughtful way, led by the needs of patients, that we use what's termed the triangle of capability to ensure that practitioners get the education that they need to develop their roles, that they have appropriate supervision and competency assessment in practice, and that is what will give them professional credibility and will enable them to practice safely and effectively and be covered for what they do. They will have robust evidence that they have developed appropriately to that level of practice.
And do we have another question from the audience?
Is there a future for district nursing?
Who wants to take that? Alison, do you want to go back?
Yes, of course, there is a future for district nursing. There may be a journey for district nursing, but the future is fruitful for district nursing because, as we know, the Scottish Government is helping align education and competencies and mapping the journey with them. Already for the Health and Social Care Partnership in the primary care sector, we're trying to, develop a brand new team. And the district nursing are nurses, and the community nurses and the health care support workers and so everybody that's involved in the community. So I wouldn't say district nursing is nae going to last. I think it's got to maybe change into to community teams that exist of different blended models that are appropriate for that area. Remote and rural is an area that has had to look at district nursing and community nursing and advanced practice as a whole. So they've got delivery teams that work at all levels. Level 7s can manage level 3 responsibilities and level etc. But I think depending on the infrastructure, depending on where you work, district nursing has got a role, but maybe it might have a different title in the future. Put it there.
Linda, do you have an opposing view?
No, absolutely. I think there will continually be a role for district nursing. The movement is that we keep more people at home, look after more people at home. So therefore we need district nurses to be able to do that, or nursing to be able to do that. And in fact, it might be that you will be able to get into a district nursing role or a community nursing role much faster than we did in the past. I was a district nurse, but normally, you worked in the acute sector for a time before you went into community nursing. But I think now there is encouragement that you can go straight from registration into community nursing and then on to district nursing. So there will always be a role. As Alison says, it might be a little bit of a different role, but it's always going to be there.
And then finally, just before we finish up, I'd like to just ask all the panel, what's the next step, or what's the next future direction for advanced practice? Alison, we'll start with you.
I'd just like to focus on our journey so far. It's collaboration for the Scottish Government, for the patient safety programmes, for the HEIs, from NHS Grampian, from other health boards working together to actually be transparent and also plan collaborative working. so that we can join all the competencies for education to clinical competence to mapping and changing people's journeys and the teams so that we can make it a better place, but also focusing on what the Chief Nursing Officer and Chief Medical Officer really are quite passionate about, and that's care at the right place and care at home, and investing in the future for me, because at the moment I am at an age where I'm okay to work, but I need an infrastructure and a workforce that's got to manage me in my remote and rural cottage. So I would like to get ready for that.
I think a key thing for me is about developing as we were saying earlier, about having a more robust process for addressing the pillars of practice within advanced clinical practice roles. I would like to see more clinical academic careers. I would like to see more lecturer practitioners. I would like to see quite a lot more of those sorts of roles in the future. I think we have started a bit of a journey between Robert Gordon University and NHS Grampian with that, but it's early days, and I think there's a lot of really fruitful posts that we have the ability to develop if we keep working on it. And that really would be my ambition, along with a better succession planning pathway, because as Alison rightly says, there's many of us in advanced clinical practice roles who are very, very much nearer the end of our careers than the beginning. And if we don't have robust pathways to develop people, I don't know where we're going to, our replacements are going to come from, honestly.
I would echo what you've just said, Karen. I suppose for me it's about looking at different models of advanced nursing practice and what these might look like, so the clinical academic careers and such like, because as we've already discussed, to achieve in these 4 areas is a tall order. But I think there is scope with the size of the nursing workforce, that there is scope for us to have different models of advanced practice with different emphasis, because one size can't fit all.
With my paramedic head on, I think that advanced practice is developing really rapidly in our profession. So the sky's the limit. Certainly as paramedics become more embedded in primary care and out of our services, I'd like to see advanced practice really take a leadership role. I think there's a potential there to certainly develop new models of care. Definitely we're at the front line, and usually people at the front line are the best people to know what's best for their patients. So I think we could have a huge impact there in developing new models of care and different ways of practice.
Thank you. Certainly for pharmacy, I see us taking increasingly clinical roles. I think we're very lucky in Scotland. We're a small country and people speak to each other, and the Scottish Government has a very clear vision for how pharmacy can contribute to provision of a safe and effective health and social care. They're putting money behind it, which is nice. The money is, I think the planning is fairly long term. I think we've got confidence in the direction that we're going. And yeah, I think the supply function will always be important, but it's about working in teams, upskilling members of teams so that people are doing appropriate things with their level of expertise. And certainly the government's behind that, and we're working very well together.
I think the future of advanced practice is rosy. I think we've got a little bit confused when I would have first started as a nurse practitioner. It was very clear that was a very clinical role, and then NEST came along with their advanced practice roles and their 4 pillars, and I think all important. But as others have said, I think it's going to be impossible to major in all 4 pillars. So as an advanced clinical practitioner, the clinical pillar has to be your high bit, and perhaps with a little bit with research. I would like to see more research in there. So perhaps, like the doctors can can manage a clinical career and have research. So that would be good if we could do that in terms of advanced practice. But I don't think we'll ever be able to have all 4 pillars at the same level. But there is opportunity that if it's research, then that's going to be your big pillar, and the others will be a little bit less. So I think probably we might have been a little confused with advanced practice and the nurse practitioner clinical role. But I see advanced practice roles across the board, but at different levels depending on what your area of interest is, whether it's clinical research, education or management. I'm
excited about advanced practice, but more about waiting to see what type of model that means for our children and young people. The main drivers are getting it right for every child and how we work with social care, health, but also education for our young people. And I would like to see more advanced practitioners within paediatrics and providing that care and supporting families, because I think early intervention is the way to go in the future, so that we have that workforce to look after ourselves in that remote rural cottage when we all retire.
Okay, I would like to finish by thanking very much our esteemed panel for joining us today and for the audience for tuning in. Thank you very much, everybody.
I think you did really well, Nicola.